Good evening, ladies and gentlemen. My name is Russ Thomas, and I'm the CEO of the Prostate Forum of Orange County. It is our pleasure tonight to bring to you one of the highly regarded speakers that we provide for your information pleasure the fourth Thursday of every month.
Dr. Chin is the assistant professor in the Department of Urology at UCLA. His subject tonight is robotic assisted laparoscopic radical prostatectomy. Everybody in the room is well familiar with that term. We've all heard it 1,000 times. He will talk about, most importantly, Richard, preoperative evaluation, including the use of MRI in biopsies. How much did we talk about that tonight already? And his surgical planning. He will illustrate surgical techniques with video excerpts. We're going to have video excerpts?
A couple.
A couple? We've never had a successful video here. I hope yours is tonight. Okay. He will discuss post-operative surveillance, including the use of novel PET imaging for biochemical PSA reoccurrence, the thing we all hate to hear or think about. Dr. Chin's CV, or biography, is way too extensive to cover here. So I'll try to hit the highlights that I picked out. I think he had 13 pages or something like that on the CV. You don't know about that. Your staff does that for you, right? So, I looked at honors and awards, and that seemed pretty dramatic to me, so I'll cover that. Starting way back in 1991, he had the Yale Book Award. In 95, he had the American Institute of Chemists Achievement Award at Princeton University. In 1995, he was summa cum laude at Princeton University. At 2000, Dissertation Year Fellowship, University of California, Los Angeles. 2003, Alpha Omega Alpha, University of California, Los Angeles School of Medicine. 2004, the Longmire Surgical Society. ConMed Surgical Research Prize, University of California, Los Angeles School of Medicine. 2005, first place, Best of Poster Session 3, American Urologic Society, Western Section, Maui, Hawaii. 2007, Career Development Award, UCLA Prostate Cancer, SPORE. 2008, Career Development Award, UCLA Prostate Cancer, SPORE. 2008, Guy de la Riva Award, Department of Urology, UCLA. 2009, the Longmire Surgical Society, Surgical Research Prize, University of California, Los Angeles School of Medicine. 2009, STOP, Stop Cancer Research Career Development Award. 2010, AACR, FNAB Career Development Award for Translational Cancer Research. 2013, Best Reviewer, 2013, Journal of Urology. 2014, Honorary Professor, First Jilin Hospital, Jilin University, Changchun, PR, China. Did I pronounce that right? Close enough. Now, I said a lot of things there. I'm not sure what all those awards mean, but sure is an impressive list. So that's why I thought I'd read it. Dr. Chin has given 40 lectures and presentations. He has 19 research papers that are peer-reviewed and 3 patents. It is with great pleasure tonight that I introduce to you Dr. Arnold Chin from UCLA. Dr. Chin, please come on up.
Thank you for that kind of introduction. So today, I will give kind of a very broad overview of kind of the considerations I take seeing a patient with prostate cancer, talk about the thinking process behind selecting someone for surgery, and then talking a little bit about a robot-assisted laparoscopic radical prostatectomy. So no disclosures, and this is kind of the general outline. So as it was discussed, we'll talk sometime just a general background about prostate cancer, just to get everybody on the same page of the way I'm thinking about prostate cancer. Talk a lot about some of the new preoperative biomarkers, genomic markers that have been introduced in the last few years. Talk about imaging, the standard imaging, as well as the use of MRI. Talk a little bit about surgery. We have a short little video telling about some of the techniques and some of our technical nuances during the surgery, and a little bit about the PET scan that we can, a new one that we're introducing that may be more sensitive in picking up biochemical recurrence. So everybody probably knows this statistics quite well, but this is actually very important. I mean, in prostate cancer in men is the highest incidence of prostate cancer yearly. It's about 180,000 per year. And it's the second leading cause of cancer death in men at about 26,000 per year. But as you can see, it's not so much the number and where it lies in the ranking, but it's really the disparity between the incidence of prostate cancer and the number of deaths of prostate cancer, which really suggests that for a majority of people, prostate cancer is not a lethal disease. And so a lot of the kind of contemporary research and thinking and management of prostate cancer the last decade or so has really been influenced by these numbers and really trying to select, well, which patients can we watch and perform active surveillance on, and which patients do we really need to treat. And that's kind of a little bit of a part of what we'll be discussing tonight. This just shows kind of a complex, but it basically shows that at this diagnosis, the majority, probably about 70 to 80% of people diagnosed with prostate cancer is localized. So the treatment of localized disease is really the kind of forefront of prostate cancer. So minority of patients will be initially diagnosed with nodal involvement, lymph node involvement, or metastatic disease. So out of the 180,000, so these kind of thinking process and questions really pertains to the majority. This slide I'm using just to show kind of the overall treatment scheme of prostate cancer and where we're going to talk today. So this is kind of a timeline of prostate cancer as time goes on for, let's say, any generic individual and suffering from prostate cancer, and this kind of y-axis is disease progression. And so if prostate cancer remains localized, majority are asymptomatic without any symptoms. They're localized or non-metastatic, and they're also what we call castrate sensitive, meaning that they're sensitive to androgen deprivation or the blocking of testosterone. And as the cancer progresses, they become symptomatic, metastatic, and resistant to hormone therapy. As you can see, the ups and downs of the different treatment options we have. What we're talking about today is going to be focused on localized prostate cancer, and it's really kind of the lower part of the graph here, where we consider the surgery of prostate cancer. Although this is slightly shifted over, meaning that we're probably operating on higher risk prostate cancer last few years, and finding that that's going to play a bigger impact. And notably also, a lot of the work at UCLA, for instance, actually has been in prostate cancer. And we've actually developed enzalutamide, which is a hormone therapy used in second-line hormone therapy. Prostate cancer was developed by research done at UCLA, and abiraterone was developed by one of our urologists at UCLA as well. So we have a long history of research in prostate cancer at UCLA. So we all know about PSA and the use of this in screening and detection of prostate cancer. So what is PSA? It's actually just an enzyme that's produced by the prostate. It really doesn't have anything specific to do with prostate cancer. It doesn't drive prostate cancer. It's really an enzyme that's important in liquefying semen as one of the kind of functions. However, anything that disrupts the prostate gland, such as infection, trauma, or a cancer that's breaking the gland open, can release this PSA into the bloodstream. So it's not a prostate marker specifically, but it's a kind of a prostate injury kind of marker. And so PSA was developed in 1987, and you can see in terms of the cases, once it was developed and used in screening, we found a lot more prostate cancer. It makes sense because we could detect it at an earlier stage. And over the years, there has been some decline in the mortality from prostate cancer, likely as a result of the screening. And the reason I bring this up, and I think this has been discussed in previous forums, is based on the US Task Force recommendations on PSA screening. So this is something that maybe a lot of your physicians have talked to you on a personal level, but whether or not we should be screening for prostate cancer. And I do want to touch base with this because this is a question that I get frequently. Should I screen for prostate cancer? Back in 2012, this US Preventive Service Task Force recommended against PSA screening. So this is based on a population level. So it looks at the number of PSAs we're drawing, the number of biopsies that are done, and they determine around, it was like every 1,000 people you screen, you could potentially save a life. But I think that may work in some ways on a large population scale, but then we have to think back, well, what are the consequences? This is still the second leading cause of cancer death in men. And part of their concern was that because we were, everybody were diagnosing prostate cancer, back in the 80s and 90s, we were actually treating for prostate cancer. We were treating with either surgery or radiation. And also the number of biopsies we're doing were not totally insignificant in terms of risk of infection and potential sepsis or significant infection. So they were concerned, or the task force was concerned by some of the secondary effects of PSA screening. And I just kind of wanted to give the excerpt because just recently they're doing an update. So this will be released probably in the next few weeks. This is just a preliminary update. But now they're recommending that screening, at least the exact words are, the decision about whether to be screened for prostate cancer should be an individual one. They're now giving it a higher recommendation in patients 55 to 69, and they're still not recommending it in patients over 70. I mean, this is kind of something that's, I think it's, obviously it can be important on the global or nationwide healthcare standpoint. But in the end, how I see it is based on the individual level. So we're not a population, each person's an individual. And I think there are other specific factors that take into account besides just a numerical age. It's going to be health, comorbidities, kind of the expected life expectancy. So at least our American Urological Association and other kind of groups will be kind of coming out with their own statements based on this. So, but because of this, actually has not all been negative, actually. So because of this recommendation, we've really now become more aware of how the patients we're treating, which patients we're treating, and really asking the question, are we over-treating patients or not? So even though this talk is really going to be, some of the focus is going to be on robotic prostatectomy, probably the most difficult decision is, who we should treat rather than actually going and performing the procedure, which, we have done. We've had good success, and we've actually really refined the surgery. So this is from the National Cancer Network guidelines of risk categories for prostate cancer. And this is actually a very important graph in terms of how we should think about prostate cancer. And we could broadly think about it in risk groups. This is very simplified. They're much more complicated nomograms, but in the end, it doesn't change very much from this. There's a very low or low risk, something we call intermediate risk, and high risk. And it really is based on several things. The stage, and this is based on the digital rectal exam or the physical exam, the PSA number, and the biopsy results, the Gleason grade. So again, I think for this audience, you guys are well aware of Gleason grade, but it's basically what the pathologists look at on the biopsy. And Gleason was a pathologist back when you first described this, and it comes in a score of 1 to 5. Over the years, we kind of refined the grading, so the lowest risk is Gleason 3, intermediate is 4, and very aggressive is 5. And there's two numbers. You always see a 3+3 or 3+4, and that's because there's some heterogeneity in every cancer. So we look at the first number being the majority of the biopsy specimens, and the second number being kind of the lesser or minority. Sometimes we even find a tertiary score, for instance. So based on this, we have these risk groups. And from that, the task force recommendation, we've actually developed this very low risk category. And, or actually it was developed around the same time. But that's important because this is really the kind of the guidelines for our active surveillance cohort. So we feel that patients with Gleason 6 or less, with a PSA less than 10, that have, based on exam, we don't feel any nodule or any kind of extension of the cancer. And these characteristics, less than 3 cores of the biopsy positive for cancer, each individual core having less than 50% of cancer, and then something called PSA density, which gives us a kind of appreciation kind of refines the PSA, because PSA is just a number, but it's also relative to the size of the gland, meaning that men with larger glands may have a naturally higher PSA just because of the purity of the volume. So the density is actually important as well. So this is the kind of the generalized criteria, or the kind of accepted criteria for active surveillance in prostate cancer. And we'll talk about a little bit about our experience at UCLA on this regard. And then now more contemporary thinking is observing and including the low risk categories in this active surveillance. And patients with intermediate risk, meaning an element of Gleason 4 or anything above that, we have to seriously consider potential for treatment, because these are the patients that are probably at risk for progression and spread and even death from prostate cancer. So more recently, and this has really been exploding in the last several years, is all the different new biomarkers. And these are biomarkers that you probably see in magazine ads now, in even commercials. And so originally, from the late 80s till probably a few years ago, we just had PSA. And then more recently, we had a test called PCA3 that, for patients who have an elevated PSA, we're not sure if we should biopsy or not biopsy, or patients who have a negative biopsy before, we've developed other tests. So these have grown. There's now a PHI, which is this PCA3 plus another gene, and these tests are done from a urine test. So after a digital rectal exam, where you kind of press on, massage the prostate a little bit, you do a urine test to find this. It's a PCR, or a kind of an amplification of a gene that's found in the urine. And other kind of blood tests that are looking at different nuances in the PSA. So in terms of who to biopsy, we have, originally PSA, now there's several other tests available, even to who to rebiopsy. So we know that in men who have a negative biopsy, when you have probably about 25% of prostate cancer, statistically, if they elect for another biopsy, or there's a reason to get another biopsy. So that means that for patients that are potentially are up for another biopsy or recommending another biopsy, majority or 75% of them are going to be negative. So really, there's other tests that are now being developed to ask that question: who should we rebiopsy? And then who to treat. So this has been really an explosion in the last few years. So these are genomic tests. They're all looking at different things, and they're based on different cohorts. For example, Oncotype DX is looking at one is looking at the risk of biochemical recurrence after prostatectomy in 5 years. One other test is looking at the risk for metastasis in 10 years. So it's based on large populations. They've then looked at the genes from these cancers from these populations and developed these tests. So these are tests to be aware of, something to consider if you have or you're unclear on a decision. How I use them, I don't use them for all patients. It's really if it's going to change my mind. When I order a test or any kind of intervention or imaging, it's really done to see if it's going to change my decision of how to proceed. So if I have a question about how to proceed, or then we can elect to do some of these tests. But I personally don't do them routinely. And then in terms of a new patient with prostate cancer, that newly diagnosed prostate cancer, what are the recommendations for imaging? And this is fairly, it's not controversial, but I do see it kind of misapplied often. A lot of times patients, we see a lot of patients for, second and third kind of opinions, and a lot of them will have, every scan that, you can imagine, but really for PSA less than 20, there's probably no real significant reason to get a CT scan or bone scan. So the risk of having lymph node disease in that population with the Gleason actually less than 7 is very, very low. So generally, our recommendations is PSA less than 20 with no high-risk features, meaning no Gleason higher than 7. We don't recommend CT scans or bone scans. However, the MRI, I think what we alluded to in the beginning is actually is a little different. And so this is, when we talk about MRI, we're talking about something called a multi-parametric MRI. And this is something that we started doing at UCLA, kind of invested for probably about 20 years or so. This MRI was first developed around the early 1980s. And it was a kind of what we call a 0.35, or a very, very low magnet. So MRI doesn't have any radiation. It's actually a big magnet that kind of aligns small water particles in your body. And so different densities of tissue, including cancer, will respond differently to when applied to the magnet. And more recently, we have even 10-fold times the power of the magnet, 3 Tesla magnets. And so we're looking at what we call multi-parametric. So these are different computations of this MRI. And there's 3 different kind of views we look at in terms of looking at for the prostate. So if you think about it, it's kind of very interesting. I mean, there's very few cancers that, previous to this, we would do surgery, we would treat without any imaging. It's probably because we couldn't image it very well. CT scans, ultrasounds, we really did. So we would actually take patients to surgery. This is when I was training not too long ago, without any imaging at all, except just a biopsy and feeling the prostate through a digital rectal exam. But now that's changing and for the better. And so MRIs aren't perfect. From our studies at UCLA, we find that they could probably detect about 75% of a clinically, what we call clinically significant tumor. So these are Gleason 7 and above. We can detect about 75% of them. The lower grade, or Gleason 3+3s, or smaller tumors, we actually are not as sensitive in picking it up. So it's not perfect. We're working on new techniques to better image prostate cancer, but it's becoming a lot more effective. And so there's two kind of main topics I want to talk about pertaining to the MRI. And one is doing the MRI ultrasound fusion biopsy. And one thing I have to say about the MRI is, as of now, it's still not the standard of care. Meaning that if a person has not gotten an MRI and proceed with surgery or had a biopsy without an MRI, it's definitely not breaking the standard of care. This is, in some ways, investigational, but now there's a lot of evidence showing the benefit of this. So one is the MRI ultrasound fusion biopsy, and this is actually was one of my colleagues at UCLA, Dr. Leonard Marks, was one of the kind of pioneers in doing this. So he started this about nine years ago, and using the MRI and using kind of computational, they basically fuse the images. So MRI is done earlier, and it's a kind of a static images, whereas ultrasound is more dynamic, meaning that an ultrasound is done at the time in the clinic, and we manipulated the ultrasound. We could manipulate the ultrasound. We could see different areas of the prostate, and the convention has been using the ultrasound and using that to guide and direct the biopsies. And we've been doing for decades what we call systematic biopsies. We basically mentally, with the ultrasound, kind of map out 12 areas of the prostate. Originally 6, and then more recently was 12 biopsies. So the standard was 12-core biopsy. But, and it's done in kind of a systematic or random fashion, just kind of getting the different areas of the prostate. Where this has really changed is that it's almost like a real-time fusion. So the MRI is downloaded on this machine, a computer, and then it's linked to the ultrasound. So when you move the ultrasound, you get a kind of a fused image of the ultrasound as well as the MRI that was done previously of every individual patient. And we can not only kind of see where the potential lesion is on the MRI, but it also records where the biopsy is done. So for instance, and it's becoming very, very helpful for our active surveillance populations, where we want to repeat a biopsy. Let's say we find a tiny focus of Gleason 3+3, let's say less than 1% in one core. We're probably not going to treat these patients. But let's say the PSA goes up in a year or 2 years, and we want to go back and see if that particular area has changed. Now we have the ability to do so. So we store all our images and we can actually go back and then re-biopsy that area. And so this is kind of the 3D reconstruction of every patient that we biopsy. And Dr. Marks has done biopsies on over 1,800 men. So the last, so about 200 years. So he's pretty much full-time in the clinic doing these MRI fusion biopsies. And he's published quite extensively on this, and we've been able to find cancers missed by conventional biopsies. We have many examples of men that had 3 or 4 negative biopsies. The PSA is constantly growing, and then we find a lesion that's not in a typical place by MRI, and then we're able to biopsy and detect the cancer. It improves patient selection for active surveillance, meaning that it's very sensitive, or it's more sensitive for higher risk disease. So we have an important finding on the MRI, then we can be more concerned about the patient, and maybe they may not be as good candidates for active surveillance. As I mentioned, talking about serial tracking of the cancer. And when it's negative, it has also something what we call negative predictive values. It's pretty good at detecting more aggressive cancers. The flip side is true as well. We have a negative MRI, despite, let's say, a PSA that's somewhat concerning. This can provide some reassurance to patients. So now we're kind of talking more about, in terms of the surgical planning. So the MRI also has very, very important in surgical planning. So in my area, I don't do as much active surveillance, but Dr. Marks and others have sent me patients that were for consideration for surgery. And how is this important? So this is kind of a cross-section of schematic. So this is the prostate gland here. This is the urethra where you void, and this is the bladder. So what's shown here are the nerve plexus. So it's coming from the sacral nerves, the S2, 3, 4. And you can see it's not a single nerve. It's kind of a plexus supplying the bladder, but also enveloping the side of the prostate and going down to the urethra. And so these are the nerves, or the neurovascular bundles you're probably always hearing about, that are important for erection. So they don't necessarily are important in supplying the prostate per se, but they travel along this posterior or back area of the prostate, going along to innervate the kind of the musculature of the penis, and that's important for erectile function. So Pat Walsh was a very well-known urologist who was chairman at Johns Hopkins for decades, really defined this anatomy, and actually for historical reasons, he was a resident at UCLA, so he started this kind of his investigation in finding the neurovascular bundles at UCLA, so he said all roads kind of go back to UCLA for prostate cancer. So, but all kidding aside, so this is, in terms of nerve sparing. So this is what I illustrate to patients frequently in terms of, how I think about nerve sparing. So this is, again, an axial cross-section of the prostate. And this is just a schematic of how the nerves lie. So you see here, the nerves lying around here. Well, these are just kind of what we call the neurovascular bundles. And as I was showing in the video, it's not that well defined. It's kind of these microscopic almost nerves with these smaller vessels. And so depending on how aggressively you want to do nerve sparing, we can go closer and closer to the prostate. Well, it doesn't look that difficult, right, to take these nerves off to kind of get close to the prostate. But it's actually not so much can we spare the nerve, it's really should we spare the nerves. And so, unfortunately, the prostate cancer arrives from this transitional zone here. So most prostate cancers, probably about 80–90%, arise from the same area. And a lot of those prostate cancers, I'll show you the pictures next, can protrude through the capsule, what we call extracapsular extension, or if we look at the T stage, we call that T3. So anything T3 is protrude beyond the capsule of the prostate. So when you have extracapsular extension or that, then doing an aggressive nerve sparing, saving all that, saving on the rim of the capsule will actually be a negative factor. You'll probably get into the prostate cancer, and then you may have a biochemical recurrence or a persistent PSA after prostate cancer surgery. So certainly, technically, we could do nerve sparing on almost anybody. We could actually stay close to the prostate and do that. But it's really, should we? And so this is where the MRI has actually really helped us. Before this, we don't only rely on the MRI, but we rely on the PSA, we rely on the biopsies, the physical exam, meaning if I feel a nodule in this area. but it's also confirmed and reassured with MRI. For instance, the MRI, if it shows potential abutting the capsule or extending the capsule, certainly I'll be more vigilant about it during the time of surgery. So this is just an example of one of my patients, and we felt a nodule on the this is a schematic MRI. So this is the again the patient is lying on their back and their feet are facing towards you. So this is actually the hip bone or the femur, the leg bone. This is the rectum, prostate. This is the pubic bone. So this is the patient's facing, head facing this way, back facing this way, and they're facing towards you. So this is a cross section. So this is the prostate, cross section of the prostate here, showing this darker area. In this particular view of the MRI, prostate cancer, it's hard to tell here, but it actually shows up a little darker in this what we call T2 weighted image. And you can see it kind of protruding in, or kind of breaking the outline of the capsule. So based on the exam, we felt a nodule there. This is I think a Gleason 3+4, and we saw this in the MRI. So based on that, I performed what we call nerve sparing on the right side. So you can see the clean, glistening capsule on the right side of the prostate. So this is a kind of the actual prostate. And then the left side, you can see it here, is kind of a more ratty tissue, and there's a rim of tissue along there. So that actually represents the neurovascular bundles that we left some behind. Most of the time, you don't have to take all of it. You can leave a portion behind, kind of consistent to our physical findings in the MRI. And this kind of gives them a better chance of retaining erectile function, but yet getting negative margins, which is a very, very important kind of reason we're doing the surgery. So this ended up to be consistent with T3 disease. His PSAs had been negative to date, and so we were happy that we had this the imaging and kind of what we call the pre-surgical planning. So that's probably a very, very important step in terms of when we approach the surgery. I won't really touch on this, but just to think about prostate cancer again, we have many options: active surveillance, surgery, radiation. So surgery and radiation are ways we treat localized prostate cancer, and then potentially other treatments now that maybe will be interesting in a later time. We're doing trials on what we call focal therapy at UCLA, where we're only ablating or treating half the gland. And based on our imaging, but it's still very investigational, and we're doing it only in the guise of a clinical trial. So for our purpose, we're talking about more localized prostate cancer and then surgery. One interesting thing, and it pertains to the use of the MRI and surgery, is now because that we're treating patients with more aggressive cancer. So I did look back in the last few years. Probably about 50 to 70% are T3 or above. So I'm definitely treating a lot higher risk prostate cancer, most likely because we're performing active surveillance on more men, and a lot of the patients I'm seeing are either ones that just have more aggressive disease, or actually a lot of them are men that progressed on active surveillance. So we know of these characteristics that are good candidates for active surveillance. Historically, about 30% on repeat biopsies and following up PSA will progress or will get treated at some point. So it's really changed my practice in terms of the patient population that we're treating. So the goals of any treatment, a localized treatment of prostate cancer, including the radical prostatectomy, what we do is we remove the prostate and the seminal vesicles. The seminal vesicles are small glands in the back of the prostate that are attached to the prostate. They can be involved with cancer, so that's why we remove them. Also, it's part of the prostate. It's where a majority of the semen volume comes from. So the fluid from the semen arises from the seminal vesicles. And we remove the lymph nodes. So we sample the lymph nodes, and we're actually doing more and more extensive lymph nodes. So this is kind of a important topic in our meetings, is how extensive lymph nodes, but we're finding that we can improve staging. And for a certain population of patients with aggressive disease, we find that if we remove all the lymph nodes, and even if they have limited cancer, they can have improved outcomes. So we're actually surgically treating more and more men with surgery, more aggressive cancer with surgery than certainly 10 years ago when I was finishing my training, where almost all the patients were Gleason 3+3 or 3+4. So we were probably addressing the ones that may not need to be treated, and the ones that are more aggressive, we were probably treating, we were more conservatively with hormones and other systemic therapy rather than surgery, but we're finding now that surgery can improve the outcomes of these patients. So we probably heard of the trifecta of prostate cancer surgery. It's just kind of a saying that, kind of what are the main goals of performing the surgery. Cancer control is probably a major goal, and then maintaining urinary continence, so not leaking after the surgery, and minimizing the effect for erectile dysfunction. So those are the major things. Otherwise, there's always a risk for other complications, but generally it's a pretty safe and low morbid surgery. And more recently, we've probably heard in other talks about robotic surgery and what is the purpose of minimally invasive surgery. So the goal, these are kind of the goals that I think are important, is decreasing the convalescence and the hospital stay, blood loss, and the traditional open radical retropubic prostatectomy was I thought, a very good surgery, but there was probably about a 10% blood transfusion rate with the surgery because the prostate is very vascular, there are important vessels surrounding the prostate. So one of the risks of the surgery was the need for transfusion. Most patients doing the open procedure stay about 2 days in the hospital. The other potential benefit is improving cosmesis, decreasing complications. And when we first started doing this minimally invasive surgery, we weren't really thinking that we were going to do better than open surgery. We were just looking for what we call oncologic and functional equipoise. We're trying to at least be not inferior to the open surgery. And then there's certain challenges to developing a new technique, different instruments, different way of communication, and then the training involved in that. So why has the robotic been so useful? There was a kind of a several-year period where we're doing just laparoscopic. So laparoscopic instruments are like chopsticks, if you think about it. They're rigid, they're going through small little ports. Similar to the ports, which I'll show you in a few slides, that we use for robotic surgery, but the benefit is that there's a wrist movement. So it kind of mimics the natural wrist movement we have in our hands. And when we operate, we're not operating as rigid kind of arms, but we're bending our wrist to basically based on the individual anatomy. So there's increased articulation. We have stereoscopic view, so we have depth of vision. Everything's magnified tenfold. There's 2 cameras in parallel, so it's almost like you get depth of field and you almost get 3D imaging. Unfortunately, none of the videos I'm going to show can really represent that. And it's fairly ergonomic. You can do several of these surgeries and not really fatigued from doing that. But the caveat, what I do want to stress, is that it's just a tool. So it's not automated, it doesn't do anything on its own. So it's really only as good as the person who's using it. So the robot doesn't do anything automatically. So if the surgeon or I decide to cut something that we shouldn't cut, it's still going to perform that, right? So because some people may ask me, well, are you going to do a better surgery? It's better in some way, in some respects, but it's still depending on who's doing it. And in kind of the global view, it potentially has a little bit more cost to it. But it's really here to stay. So this is kind of the trends, basically the numbers that we're doing robotically. It's about 60,000 a year now in the US. But it was commercially available in 2001. So in 2000, 100% were done, all these surgeries were done open. By 2005, it was about a quarter done robotically. This is 2011 figures, and it's about over 80% are done robotically. I bet the number is over 90% now. So I think a majority of this technology is diffused into almost every community. So it's not really a unique technique now. It's probably the standard. But at the same time, whereas there was differences in open surgery, there's certainly differences in robotic surgery as well. So, just during at least the first few years, there's definitely a team approach to surgery. I think there's some differences to open surgery in that the surgeon, this is actually me on the console, so I'm looking at this console. We're in the same room, but it's more isolated than if you're doing open surgery. Open surgery, you're talking, you're face to face, you're up close to the patient. Here, we're not sterile, we're kind of a little bit more isolated. We're talking to a microphone, as I'm talking to you today, so it's a little bit different communication skills involved. So from that, we've learned that we need a kind of a good game plan with an entire team. We have dedicated nurses and physician assistants who are standing at the bedside next to the robot who are trained in doing these procedures. And there's always a possibility for need for alternatives and open conversion. We always have everything that's necessary to do the traditional open surgery in case of any kind of failure of instruments or any requirement. And as of now, I've actually haven't converted one. But John Whitten, one of our UCLA coaches, had the quote saying, "Failing to prepare is preparing to fail." So we always are very prepared for all situations. This has been really interesting, more so from the academic standpoint in terms of learning. So now the residents going through our program, they're learning the surgery for the first time, seeing it robotically. So they're not even doing any open surgery anymore. So this is actually kind of from our perspective in an academic center, kind of an interesting perspective. And as I mentioned before, the communication is a little bit different. So it's changed the way we do the surgeries. I do, not only prostate cancer surgery, but I do all urologic cancers. I do all my kidney cancer, bladder cancer surgeries, probably about 95% or so robotically these days. This is kind of where the ports. I actually don't use the yellow one, so I usually use 5 different ports. We have a camera going through one. This is the largest one, about 12 millimeters in size. 3 of the robotic ports that are going through 8 millimeter incisions, so that's pretty small incision. I don't use the yellow one, and then we have an assistant that's handing us instrument or handing us sutures or doing other exposure through the side. So we have someone by the bedside at all times. This is actually the robot docked onto the patient, the same kind of port placement, and you can see the robotic instruments attaching to these trocars, and then we actually didn't show here, but we placed the instruments through these little ports connected to the robotic arm. So the arm's kind of hanging, between the legs of the patient in this case, and then it's connected to these ports. And where usually you could do these surgeries remotely, but we're usually in the same room. So now I'm going to attempt to show this video. I think I just have to toggle it here. Let me just go over here. It's actually just a couple of minutes, but just kind of illustrates some of the points we were talking about, and see if I can do this successfully. Yeah. So this is actually nerve sparing, and so you can see these neurovascular bundles. So one part of it is vascular. So everything's magnified. So this is probably about 2 cc's of blood, but it looks like a lot. But here again, this is the left side of the prostate. This shiny capsule is the prostate, the capsule. This is the neurovascular bundle. So here, the cancer is on the other side predominantly, or actually this side, I think I did bilateral, this patient did bilateral nerve sparing. You can see a little vessel here. This instrument here is probably 5 millimeters in length. So we're talking about very highly magnified. The prostate itself, an average is probably maybe 30 cc's, so about a walnut size. So you can see how magnified we are. And this is actually the urethra. So this is actually one of the techniques of regaining continence is leaving a very nice preserved urethra. This is the pelvis here, the nerves on the side. This is the deep pelvis, and I basically pulling back and getting the longest urethra I can at the apex of the prostate. So this is actually the catheter, the Foley catheter that you're going to see exposed. This is the urethra that we're going to reconnect the bladder to. So you can see, again, that was an assistant suctioning so we can see things. And we're making probably a couple of millimeter incisions. So it looks a little bit tedious, but this whole surgery probably takes 2.5 hours to do the whole thing. That's including removing the lymph nodes, dissecting, separating the bladder from the prostate, and then doing defining the blood vessel of the prostate, do the nerve sparing, and do this. And then after this portion, we actually will just bring up and suture the bladder to the urethra. And so the 2 important points that we're talking about, the cancer portion of the surgery is, this whole procedure is important for that. but the nerve sparing is important for the erectile function that I showed in the first half of this clip, and then preserving these the muscles. So this is actually called the levator muscle. So these are the muscles that are surrounding the sphincter, which is here, and these are the muscles that are important for regaining continence, and then maintaining a long urethra. So those are the kind of probably two important steps of achieving the trifecta that we talked about. So I didn't want to burden with kind of like a lot of primary data, but these are kind of just the overall results in our field. So in the end, over the last 15, almost 20 years, there's no significant difference in cancer control and continence as we expected. We've really refined the open procedure over the last several decades. It's a very, very good surgery. We had great results with it. But at least we showed that there's no inferior aspect. And this is based on experienced surgeons who are both experienced surgeons. What we have shown, which is not unexpected, is that surgeon volume makes a difference. So if there is a learning curve for this technique, there's going to be good surgeons and not so good technical surgeons. So that probably plays a bigger difference in terms of cancer control continence. But in experienced hands, and what I tell patients at our center, we have over 95% of people continent. If I look back at my series, the ones that are a little, some incontinence are ones with higher volume disease, so the ones that are very, we had to treat more aggressively, that we actually got into the muscle wall just to get the cancer out. Potency, so we do an excellent job in retaining continence. Potency, we're probably not quite as good at. I would say probably being conservative is probably about 60 to 8, or realistic, probably about 60 to 80% return to potency. Obviously, there's a lot of variability in a man's potency before surgery. Age will play a difference, the other comorbidities such as hypertension or high blood pressure or diabetes will make a difference. But overall, I think we do a fairly good job. And I'll tell you in the next couple of slides, I'll tell you some of the factors that are important in this. And we try to minimize and have minimal surgical margins. And these are what we can call these are histologic surgical margins. We rarely get gross disease. We're not cutting through the cancer that we can see, but these are diseases that are shown up on based on the pathology. So we try to minimize the surgical margins. And in general, complications are fairly low. Typically, patients stay overnight in the hospital, oftentimes even less than 24 hours. And we believe that doing this robotic approach, patients can get back earlier to normal activity. So I think we've been pretty successful in that. This is actually published by a visiting professor that was from China that was visiting me, learning robotic surgery from me, and he wanted something to study. And so this was actually probably about a 3-year period where we took all my high-risk patients. And we looked at whether or not the MRI, and this is what we were starting to do MRI, I think this was published in 2013, whether the MRI improved our planning and ability to perform nerve sparing. And this is kind of small, but essentially it shows that even in these high-risk patients, so these are all T3 disease or Gleason 8 or 9, that if we are able to do nerve sparing, so based on the exact location, based on our imaging and physical findings, we actually were able to get good continence and potency recovery even with bilateral nerve sparing or unilateral in these cases. So about 80% return potency, 92 in this series had a return of continence with unilateral. So patients with extensive disease even on one side, and we were able to do very good nursing on the other side. We actually gave them pretty good recovery. Again, this all depends on how aggressive the disease. So patients that we did do nerve sparing, both the potency and the continence suffered. Again, these numbers are quite small, but it correlates with the nature of the disease. And so that's why we think the MRI is helpful in that, but it's not absolutely necessary, but it's helpful because it kind of maximizes and provides us with more information. And certainly if we have more information before we proceed with something like surgery, I think we're better off for it. And this just shows the histology. So what we do at UCLA for all our histology is we do what we call whole mounts. So we take the entire cross-section of the prostate and we section it almost like, like cutting a potato in some ways. And we're looking at throughout the whole prostate, looking at the margins. And so this kind of histologically shows us what a nerve sparing is. As you don't see any tissue on the side here, right? It's pretty apparent. Whereas partial nerve sparing, this is the capsule of the prostate, outlined here. You can see a little tissue left behind. This is the cancer right there. So I purposely want to leave a little tissue behind. This is leaving a little more tissue, just a very limited partial nerve sparing. And this is non-nerve sparing. So you can see tumor kind of extending out through. There's a very large tumor extending out through the capsule here. You can see all that extra tissue of the nerves. So this particular patient, I did non-nerve sparing, kind of purposefully, but I think because of the nature of this cancer. So we can really refine our surgery based on every individual, and I think that's a really key point in proceeding with surgery. Just a quick couple of slides on how we do surveillance afterwards. I mean, really, the only surveillance we need is just PSA. So PSA is not so specific before surgery, but there's no other tissue in the body that produces it. So benign or malignant prostate can produce can break the glands of at least PSA, but really only the prostate produces PSA. So after the prostatectomy, the PSA becomes an excellent cancer marker. So we generally just follow serial PSAs, and really what we call selective use of imaging. So we won't get any imaging unless there's any kind of symptoms or any other suspicion that we need to. Where I think the PET scan I think is useful is in what we call biochemical recurrence. So if we take all patients that have undergone a radical prostatectomy, undergone surgery with prostate cancer, probably about 10 to 15% risk for biochemical recurrence, meaning that the PSA will decline to undetectable levels initially, and then they'll come back. It could be either in months to even years, and even like we've seen it even a decade after surgery. So the PSA can come back, and we call that biochemical recurrence. We call it biochemical recurrence because if we image those patients early on, we can't find any evidence. We don't know where this cancer is. And based on the timing and the kind of the kinetics of the PSA, there are some patients may be amenable for local radiation therapy to the bed of the prostate based on the timing and kinetics of the recurrence. Others we may treat kind of systemically with hormone therapy, for instance. Where this is useful, and so PET scans, so PET is combined with a CT. So everyone's familiar with a CT scan. It's just basically stacked X-rays making small cuts through the body. The PET scan was actually, I'm not making this up, actually was developed at UCLA as well, several decades ago by Phelps, Dr. Phelps. But in any case, it's basically looking at metabolism. So the original PET tracer was a glucose molecule with a tiny radionuclide, so we could follow it. And so tissues that had higher metabolism will light up on the PET scan. So for instance, certain cancers may divide more quickly, and because they take up more glucose or energy source, then they'll light up. Prostate cancer wasn't one of them. And over the years, I think I saw in the syllabus that other talks about C11 choline was used that may have the choline to the ratio, the citrate ratio was a little higher in prostate cancer. So this was one way we've used to try to detect early prostate cancer. But more recently, and this is not yet FDA approved, so I think we're the only center here in Southern California with this. It's just because this has to be made on a daily basis to be used. There's one in San Francisco and other centers around the country. But it's showing kind of interesting use. So this, again, is not the standard, but it's something that we find that may be interesting. So PMSA stands for prostate membrane-specific antigen. So it's a fairly prostate-specific protein. So that's useful because if we tag this nucleotide to it, hopefully only prostate cancer tissue will light up. It's not that specific, but it's pretty good. And our original kind of early studies have suggested that we can detect prostate cancer down to a level about 0.2. So pretty low level. So this is we consider a pretty early biochemical recurrence, kind of in the threshold that we can contemplate giving radiation or not. And so we've kind of adopted using this in select patients. to see if it will change what we do. And I'll show you an example of where this may be useful. Again, I'm just going to scroll through the CT scan, and then I think I should pause on where the prostate cancer lights up. So this is actually scrolling down. You can see the kidneys, it gets excreted in the urinary tract, so all the kidneys light up. The bowel lights up a little bit. That's the bladder, but there. So that little spot there lit up. That's probably a little bit deeper than the normal lymph node dissection that we normally do. It's not in an area that normally gets irradiated when patients get salvage radiation from prostate. So in this case, it was actually helpful. So what we did in this particular patient, we actually, because it seemed like an isolated lymph node, his PSA was 1 at the time, we went back in to do a surgery, we removed that lymph node that was confirmed to be positive for cancer, and then we, the PSA declined, not to 0, but I think went down to 0.1, and then we gave a little boost of radiation to that area, thinking that there might be some microscopic disease. So in some instances like this, where before we may just kind of blanket give treatment, or give systemic therapy when we didn't know it was localized or not, this is becoming useful. So you'll probably hear more about this imaging over the years. And that's it. So that's about all I had prepared to talk about. I could welcome any questions at the time. I brought some of my cards if you have any questions, but probably the best way, easiest way is to email me for any kind of questions that you may have.
Okay. To take questions, I'd like you to raise your hand and I'll give you the mic so we can pick up the sound. Yeah, way in the back.
Dr. Chen, in your opinion, what is the minimum threshold for the number of surgeries that a surgeon should have before he becomes technically competent for doing the robotic?
Yeah, it's a good question. I mean, in the end, there won't be a defined answer, I don't think, just because, there's probably, truth be told, there's probably some people that can do hundreds and probably shouldn't be doing them, others that just need a few and they do well. But I think on average, so I trained in the era where I did almost all open radical, so that could be a good example. So I did during my resident training, we probably did about 200 open radical prostatectomies. When I finished, I started as faculty. So I've been at UCLA now 20 years through all my training, but I started as faculty at UCLA. I started doing open ones, and then I kind of learned the robotic surgery. So I would say that there was a very steep learning curve for the first 10, and then and then flattened out the next 20. But I'm still learning now. So I've done several hundred now, and I'm still finding little nuances. But I would say after about 20 to 30, the definitely learning curve flattens out. And where the learning curve I think makes a difference in my hands was that my operative times are longer. So in the beginning, I was contemplating more. I was kind of looking at the anatomy a little more carefully, learning some of the instrumentation, because since I already learned the surgery, I was just trying to recreate my open surgery techniques, but learning in a different way. So I think now it's probably going to be, for new trainees coming out, including the training, they probably should have well over 100, I think, because they're learning the surgery, for the first time robotically, rather than kind of adopting their existing techniques. But it's probably around that range. I mean, it's probably, hotly debatable, in terms of that, but in my standing, that's what I felt. But, as a surgeon, I'm constantly learning. I'm always looking for, ways to improve things. I personally record all my surgeries, so if there's any kind of question about it, or we have a difficult, challenging anatomy, or some kind of a positive margin, I'll go back and look at my surgery. So we're always trying to refine our techniques.
Question, Dr. Chin, on the biochemical reoccurrence. So after you do a radical and you monitor the PSA, where do you consider the reoccurrence? At what level? And is there potentially some PSA there, or in what kind of rise, or what can you expect?
Yeah, good question. So, again, it's different for surgery versus radiation, because radiation, the prostate is still there, but for surgery, so one of our my colleagues, he was actually a radiation oncologist that came from Stanford to UCLA, Chris King, looked at what we call a meta-analysis. You looked at all the studies you could find and see where the value actually made a difference. And we came down, and what we use at UCLA is using the ultra-sensitive PSA. We use 0.06 is what we feel is probably something real. But what that means is, so normally, traditionally PSA in a lot of labs come down to about a sensitivity about 0.1 or 0.2. But many independent labs and the ones we use come down to what we call the 100th decimal point. So we could detect it down to like the 0.01. And so after surgery, I said PSA is very, very specific, but there may be a couple of benign glands remaining. And so we often see a PSA that maybe fluctuates between 0.01, 0.03, and it kind of goes up and down. We will still monitor those. It makes us a little concerned, but we don't really act upon it. What I would do, I don't use a strict cutoff of 0.06, but I want to see a trend. And so we follow the trend. We also follow something called the PSA doubling time, which is not really linear, but we can kind of calculate the doubling time. So if we see a certain trend, and usually around above 0.06 and maybe for sure 0.1, then we may consider salvage radiation. And the reason why we're so vigilant about that is that it makes a difference in terms of the benefits from radiation. So we know that PSA over 1, in patients that get salvage radiation after radical prostatectomy or PSA over 1, they don't do as well as ones less. So the lower the PSA, kind of more successful salvage radiation would be. That's kind of why, it's a great question, that's why it's important. Yes, sir.
I've got a question. The gallium-68, I know that other countries, in fact in Sydney, Australia, they're doing it there and stuff. Do you have any thoughts on when it would be approved for in this country?
Yeah, there's several companies, actually several companies running clinical trials now. We get ours, actually one of the radiologists that was important, I forgot his name, is in Germany that actually developed it. It came over to UCLA, so that's why we have it now. And so, I think from this, we probably just need to get enough of the completion of the clinical trials before we bring it to the FDA to get it approved. But yeah, so the unfortunate part about this is, at least for our centers, it's not approved by insurance. So our patients are paying out of pocket for it, and it is certainly a consideration. So because they're really paying for making the tracer that needs to be made on site.
You have to have a special box.
You need a cyclotron to make it. So we have one at campus.
Do they have some kind of a box on the gallium-68, or is that another technique where they have these small individual generators, I guess they call
Yeah. I think we're talking about the same thing, but it has to be made, made specifically because of the very, very short half-life. I think the half-life just decays, so it's made every morning on the days we do it.
Right. Now, the quick question, the Axumin, have you guys did any comparison between the Axumin PET-CT and the gallium-68?
Yeah, that I don't know offhand. I actually couldn't give you a really good answer to that in terms of the direct comparison between the two.
So,
I probably think the answer, not 100% sure, that we just don't know yet in terms of the studies. I think, like a lot of these studies that we're doing, we're collecting the data, but we haven't really kind of compared it head to head, and that's what needs to be done.
because I think on some of them, maybe even the Axumin was done some comparison with the C11. I think
Right.
they did some just with the C11. Comparison.
Right, so and then some of our colleagues at UCSF are doing those studies as well. So I know we're collaborating with them, and we actually have a clinical trial for this right now. So we're still collecting the evidence.
So, Doctor, what with the PSA at 0.06 and with the imaging techniques that are going on today, why, as an alternative to hormone therapy, why wouldn't you consider surgery as an option? As they're going to take care of the recurrence for those cells that you can pinpoint that are large enough. There's always this question of microscopic unknown cells, but why wouldn't the surgery be an alternative rather than radiation or hormone therapy?
Yeah, that's a great question, but one that we're addressing at this point. So, I mean, I didn't show it, show it now, but that patient we actually did surgery on. His PSA went from 1 to 0.1, so it was still a little bit there, probably because of microscopic disease. You know, I think once cancer goes to the lymph nodes, so anybody with a kind of a lymph node positive disease, we all have patients that we have one node positive, we do surgery, we never see a PSA come back, but it's still the minority. So the thinking is that whatever the travel that's cancer cell to that lymph node, there's probably microscopic deposits elsewhere. So right now we're still a little bit limited even with these imaging techniques, you know, but our strategy now for, you know, young healthy patients with an isolated kind of area, we have been doing surgery on them. We follow the PSAs. A lot of them we do a small radiation boost only to that area. So it's a good question. We're kind of doing that right now, but long-term results we'll just have to wait and see. We generally don't do hormone therapy alone. So hormone, you know, in terms of androgen deprivation therapy as a kind of long-term, we don't do in those limited factors. But there's enough data now that with radiation therapy, we do a short course of hormones. So we probably do 6 months of hormones with salvage radiation, and then we feel that works better. Stand by.
Thank you for your excellent presentation. That was superb. I appreciate it. I'm sure we all do. How long has the surgeons at UCLA been using ultrasound image fusion before surgery to plan the surgery?
Yeah, so we probably been doing the multi-parametric MRI, and so probably I would say about 10 to 12 years. So I started out 8 years ago, and I knew at the end of my training we were starting to do the multi-parametric MRI. But MRIs in general, in terms of imaging, we've probably been doing it really close to 20 years. Even when at the onset of it, we were doing the MRIs. However, an MRI technology was not able to detect it. One, the magnet was not as powerful. And also, when we talk about MRIs, we're not getting the standard MRI, we call it multi-parametric. So MRIs are much more complicated than CT scans where like almost anybody can read them. What image we use is programmed in terms of the sequence of what MRIs we want to do. So we're still playing around altering that, but we have 2 radiologists that are dedicated just to reading it because it's not that simple to look at. So it requires a very, very dedicated radiologist and a lot of programming, tweaking of the MRI imaging.
And do you do that for patients who are preliminarily diagnosed with 3.4 before the surgery?
Yeah, I that's again, it's a surgeon's choice. I typically do. So again, you know, I think it helps. I think it almost, you know, if you're going to undertake something as significant as a surgery, you know, I think from our findings and our intuition, you might as well have as much information as you can. And so we find it helps more than, you know, it hurts us. And so we don't only rely on it blindly in the MRI, but we base it on everything else. We base it on the biopsies, the physical exams, the PSA, those type of things, and then we get appreciation of where we think that prostate cancer is and how close a margin we need to do.
Yeah, hi, Dr. Shin. I just had a couple quick questions. One is, how do you determine if cancer is in the lymph nodes or the nodules? And then second question is, you mentioned enzalutamide and abiraterone that was developed, I guess, at UCLA. Are they getting in any information from the testing that they're doing on those two, whether one is better than the other one, or whether both in combination are better?
Yeah, well, great question. So the first question was, again, actually, I forgot what was the first question again? Was
how do you determine if the nodules have?
So, you know, so high-risk patients, we do CT scan. Again, that's what the traditional been doing. It's probably going to change over the years, but we're looking purely at size. So our criteria for not just in prostate cancer, but in just surgical oncology or oncology in general, is looking at what we call lymphadenopathy. So it's size greater than 1 centimeter, which is, again, it's kind of random too, right? So, but But there's, anybody. So we take 100 people that have no evidence of any cancer. You're going to see lymph nodes in everybody. I can feel my lymph nodes here. So there's always some kind of size of lymph nodes. So we look for enlargement of lymph nodes. Where I think the PET falls in, is helpful is that it looks at some kind of functional assay, either a marker or some kind of metabolism of the cancer. So it's looking at size plus those, because the majority of patients that we actually find positive lymph nodes now, and still the minority of radical prostatectomy, is probably about 5% of my cases at least, they're microscopic lymph nodes. They're the ones that we don't really see any enlargement on imaging, and they may be only a 2 to 3 millimeter focus that the pathologist finds. They're early on. So, if we don't find it based on imaging, when we do the lymph node dissection, and we're doing a more what we call extended template these days, our pathologists will isolate every single lymph node, they'll section them, look at it in the microscope, and examine. So that's what we call pathologic staging, and that's kind of the standard. In terms of your second question, that's a very good question. It's actually, we don't know right now. So patients on hormone therapy traditionally get something called it's either LHRH agonist, so it's like Lupron or Zoladex. It basically works through the hypothalamus pituitary to medically castrate or lower the testosterone. So in patients that have PSA rising, despite that, there's these second-line hormone therapies. So enzalutamide, which will actually block, it's an androgen receptor blocker, so it blocks where the receptors, so minute amounts of testosterone can't really bind to the prostate cancer cell. And then abiraterone, which decreases the production of testosterone from the adrenal gland. So all these injections of hormone therapy only work on the testis, but adrenal glands above your kidneys also produce a small amount of testosterone as well, so that's where it falls in. The ordering, we actually don't know. So we have clinical trials studying that. Right now, there's probably, nationwide, we're probably using enzalutamide about 2 times more than abiraterone for no specific reason, probably because you need prednisone or steroids with abiraterone, but we don't know the sequence. So they're used fairly interchangeably now, but there's some kind of molecular rationale using combinations. So there's trials now asking that exact question. Come on.
He's on the Alliance study, which is both of them.
Yeah. Yeah. So in the end, we don't know, but if you look at the mechanism of action, which are different, there is rationale of combining two, and we have studies ongoing to really determine. But right now, there's no specific sequence, and we really don't know if combination is better or not, but it does make sense.
Thank you.
The first one and the last one, maybe, huh?
Follow-up question on removing nodules.
Yeah.
Are there negative side effects? We have an aunt that had a lymph node removed, and now she has an enlarged leg because it doesn't drain properly.
Yeah. So there's no surgery without any potential risks and side effects. Obviously there's risks of that anesthesia, risk of surgery in general, infection, bleeding, injury to the surrounding structures. But in terms of what you're talking about called lymphedema in lymph node dissections, we see it we hear about it more commonly probably in women with breast cancer, where they used to do lymph node dissections in the axillary area. It becomes a more significant problem when you remove all the lymph nodes in a certain area. So for prostate cancer and a lot of our pelvic surgery, we generally remove only a certain distribution of lymph nodes in the pelvis, but there are what we call inguinal nodes, kind of in the groin here, that we don't remove. So the incidence of having what we're describing as lymphedema is very, very rare. So in our population, we can get something called a lymphocele, which is just a lymph collection in the pelvis. Generally that's benign, but occasionally they need to be drained because they can compress the vessels. But we really don't, I wouldn't say never, but we probably have a very, very low incidence of lymphedema because of the other additional lymph nodes that are draining the legs.
We got one more.
I too want to thank you for your presentation. It's very enlightening. And they say the worst question is the one you didn't ask, right? So my question is, in those cases where one has already undergone an MRI-guided biopsy that yielded positive results, is there any benefit to a subsequent what do you call it? Multi-parametric MRI?
Yeah, so for our institution, it's one and the same. So we use the same MRI. I mean, there's some nuance to it. You can actually do something with what we call a rectal probe. So, in terms of getting better prostate anatomy, you could do the MRI externally, or you could actually do the MRI close to the prostate through a fairly large-sized bore that can actually do it. We don't find that much difference in it. So I think any type of MRI that we do, we have pretty good imaging. But for our institution, we use the same MRI. So we do a multi-parametric MRI for the biopsy, and then we take that information to fuse it with the ultrasound, because it's that multi-parametric kind of qualities that help identify the prostate cancer. And then for patients that will go on to surgery, we use that same MRI. So I guess the long answer to your question is they're for us, and the way we do it is one and the same.
He has a 3 Tesla though. Some people have a 1.5.
Yeah, we've debated that ad nauseum in our meeting over there. He's complimenting you on the 3 Tesla MRI versus the 1.5.
They have that in the Tesla.
Okay, wow, what a great presentation.
Thank you for watching our video. If you would like to learn all the most current prostate cancer information, we have many YouTube videos on our website at www.prostateforum.org. We also have meetings the 4th Thursday of every month where you can talk to mutual survivors. You can also ask personal questions to the doctors and the speakers after the meeting. Remember, when us men hear the word cancer, the big C, our brains turn to mush. We think we're about to die. Come learn where there's hope and information at the Prostate Forum of Orange County.